Okay, another conventional antipsychotic is Flupenthixol or Dipixol. Comments about that. We have depot injections of these, not available in the US. So let's talk about that. Flupenthixol, Dipixol. It has no generic, of course, in US. Neuroscience-based nomenclature, it is dopamine receptor antagonist. It's called conventional antipsychotic, of course, neuroleptic, but it is from the thioxanthine. Thioxanthine. Okay, dopamine 2 antagonist, of course. Okay, commonly prescribed for schizophrenia, depression in low doses, and other psychotic disorders, and of course for bipolar disorder. But as we said before, it's not used in USA, so it's not FDA approved for any of these. How the drug works: it blocks dopamine 2 receptor, reducing positive symptoms of psychosis. How long until it works? With injection, psychotic symptoms can improve within a few days, but it may take 1 to 2 weeks for notable improvement. With oral formulation, psychotic symptoms can improve within 1 week, but it may take several weeks for full effect on behavior. So, if it does work, most often reduces positive symptoms in schizophrenia but does not eliminate them. Most schizophrenic patients do not have total remission of symptoms, but rather a reduction of symptoms by about a third. Continue treatment in schizophrenia until reaching a plateau of improvement. After reaching a satisfactory plateau, continue treatment for at least a year after first episode of psychosis in schizophrenia. For second and subsequent episodes of psychosis in schizophrenia, treatment may need to be indefinite. Reduces symptoms of acute psychotic mania, but not proven as a mood stabilizer or as an effective maintenance treatment in bipolar. After reducing acute psychotic symptoms in mania, switch to a mood stabilizer and or an atypical antipsychotic for mood stabilization and maintenance. If it does not work, consider trying one of the first-line atypical antipsychotics like risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, paliperidone, or amisulpride. Consider trying another conventional antipsychotic, and if 2 or more antipsychotic monotherapies do not work, you consider clozapine. Best augmenting combos for partial response or treatment. Augmentation of conventional antipsychotics has not been systematically studied. Addition of mood stabilizing anticonvulsants such as valproate, carbamazepine, or lamotrigine may be helpful in both schizophrenia and bipolar mania. Augmentation with lithium in bipolar mania may be also helpful. Addition of benzodiazepine, especially in short term for agitation. Okay, tests for antipsychotics. Since conventional antipsychotics are frequently associated with weight gain before starting treatment, weight all patients and determine if the patient is already overweight or obese. Before giving a drug that can cause weight gain to an overweight or obese patient, consider determining whether the patient already has prediabetes, diabetes, or dyslipidemia, and treat or refer such patients for treatment, including nutrition and weight management, physical activity counseling, smoking cessation, and medical management. Monitor weight and body mass index during treatment. Consider monitoring fasting triglycerides monthly for several months in patients at high risk for metabolic complications, and when initiating or switching antipsychotics. While giving a drug to a patient who has gained more than 5% of initial weight, consider evaluating for the presence of prediabetes, diabetes, or dyslipidemia, or consider switching to a different antipsychotic. Monitoring elevated prolactin levels for dubious clinical benefit. Patients with low white blood cell count or history of drug-induced leukopenia or neutropenia should have complete blood count monitored frequently during the first few months, and Flupenthixol should be discontinued at the first sign of decline of WBC in the absence of other causative factors. So let's talk about side effects. So how this drug causes side effects? By blocking dopamine D2 receptors in striatum, it can cause motor side effects, of course. D2 receptors in the pituitary, it can cause elevation in prolactin. By blocking dopamine D2 receptors excessively in the mesocortical and the mesolimbic dopamine pathways, especially at high doses, so it can cause worsening of negative symptoms and cognitive symptoms. We've called that neuroleptic induced deficit syndrome. Anticholinergic actions may cause sedation, blurred vision, constipation, and dry mouth. Antihistaminergic actions may cause sedation and weight gain. Beta blocking, by blocking alpha-1 adrenergic receptors, it can cause dizziness, sedation, and hypotension. Mechanism of weight gain and any possible increased incidence of diabetes or dyslipidemia with conventional antipsychotics is actually unknown. So notable side effects for Flupenthixol are neuroleptic induced deficit syndrome. We've talked about that. Extrapyramidal symptoms, more common at start of treatment, and Parkinsonism. Insomnia, restlessness, agitation, and sedation. Tardive dyskinesia, like risk increases with duration of treatment and the dose. Galacturia, amenorrhea, tachycardia, weight gain, hypomania, or rarely eosinophilia. Life-threatening or dangerous side effects, we have rare neuroleptic malignant syndrome, rare seizures, rare jaundice and leukopenia, increased risk of death and cerebrovascular events in elderly patients with dementia-related psychosis. About weight gain, many experience and or can be significant in amount, so it's common. Sedation is not unusual, occurs in significant minority of patients. What to do about side effects? Wait. For motor symptoms, add an anticholinergic agent. Reduce the dose. For sedation, you can give at night. Switch to an atypical antipsychotic. Weight loss exercise programs and medical management for high body mass index, diabetes, and dyslipidemia. So, what are the best augmenting agents for side effects? We have benzotropine or trihexyphenidyne for motor side effects, benzotropine and trihexyphenidyne, and sometimes anantadine can be helpful for motor side effects. Benzodiazepines may be helpful for akathisia. Many side effects cannot be improved with an augmenting agent. Okay, what about dosing and use? Usual dosage range: oral from 3 to 6 mg per day in divided doses, intramuscular 40 to 150 mg every 1 to 4 weeks. We have tablets of 0.5 mg to 3 and 3 mg. We have injections of 20 mg per milliliter and 100 mg per milliliter. Okay, how to dose? Orally, for oral, we have initial 1 mg 3 times a day, increased by 1 mg every 2 to 3 days, and maximum generally is 18 mg per day. For intramuscular, the initial dose would be 20 mg for patients who have not been exposed to long-acting depot antipsychotics, 40 mg for patients who have previously demonstrated tolerance to long-acting depot antipsychotics, and after 4 to 10 days, you can give additional 20 milligram dose, and the maximum would be 200 milligram every 1 to 4 weeks. Okay, so what about depot kind of injection? Okay. Dosing tips. The peak of action for the decanuate is usually 7 to 10 days, and doses generally have to be administered every 2 to 3 weeks. May have more activating effects at low doses, which can sometimes be useful as a second-line short-term treatment of depression. Some evidence that Flupenthixol may improve anxiety and depression at low doses. Treatment should be suspended if absolute neutrophil count falls below 1000 per millimeter square. Cubic. Overdose, agitation, confusion, sedation, extrapyramidal symptoms, respiratory collapse, and circulatory collapse. Long-term use, it's safe for long-term use, no habit forming. How to stop? Slow down titration for oral formulation over 6 to 8 weeks, especially when simultaneously beginning a new antipsychotic while switching cross titration. Rapid oral discontinuation may lead to rebound psychosis and worsening of symptoms. If antiparkinson agent are being used, they should be continued for a few weeks after Flupenthixol is discontinued. Okay, pharmacokinetics. Oral, we have maximum plasma concentration within 3 to 8 hours. 3 to 8 hours. Okay, intramuscular, rate limiting half-lives, approximately 8 days with single dose, approximately 17 days with multiple doses. We have some drug interactions because, okay, may decrease the effects of levodopa and dopamine agonists, may increase the effects of antihypertensive drugs except for guanethidine, whose antihypertensive actions Flupenthixol may antagonize. CNS effects may be increased if used with other CNS depressants. Combined use with epinephrine may lower blood pressure. Ritonavir may increase plasma level of Flupenthixol, may increase carbamazepine plasma levels, and some patients taking an neuroleptic and lithium have developed an encephalopathic syndrome similar to neuroleptic malignant syndrome. We have some warnings and precautions. So if signs of neuroleptic malignant syndrome develop, treatment should be immediately discontinued. Use cautiously in patients with alcohol withdrawal or convulsive disorders because of possible lowering of seizure threshold. In epileptic patients, dose 10 to 20 milligram every 15 days for intramuscular formulation. Use with caution, if at all, in patients with Parkinson's disease, severe arteriosclerosis, or Lewy body dementia. Possible anti-emetic effect of Flupenthixol may mask signs of other disorders or overdose. Suppression of cough reflex also may cause asphyxia. Avoid extreme heat exposure and do not use epinephrine in event of overdose, as interaction with some pressor agents may lower blood pressure. Do not use Flupenthixol if patient is taking a large concomitant dose of a sedative hypnotic, if has CNS depression, if patient is comatose, or if there is brain damage, if there is blood dyscrasia, if a patient has pheochromocytoma, if patient has liver damage, if patient has a severe cardiovascular disorder, if patient has renal insufficiency, if patient has cerebrovascular insufficiency, if there is a proven allergy to Flupenthixol. So for special populations, in renal impairment, oral recommended to take half or less of usual adult dose. Intramuscular recommended dose schedule generally 10 to 20 milligram every 15 days. If there's hepatic impairment, you use with caution. For oral preparation, recommended to take half or less of usual adult dose. For cardiac impairment, use with caution. Oral recommended to take half or less of usual adult dose. In elderly, intramuscular recommended initial dose generally 5 milligram. Recommended dose schedule generally 10 to 20 milligram every 15 days. Oral recommended to take half or less of usual adult dose. Although conventional antipsychotics are commonly used for behavioral disturbances in dementia, no agent has been approved for treatment of elderly patients with dementia-related psychosis. Elderly patients with dementia-related psychosis treated with antipsychotics are at increased risk of death compared to placebo. and also have an increased risk for cerebrovascular events. For children and adolescents, not recommended for use in children. In pregnancy, it's not recommended for use during pregnancy. There is a risk of abnormal muscle movement and withdrawal symptoms in newborns whose mother took an antipsychotic during the third trimester. Symptoms that may include agitation, abnormally increased or decreased muscle tone, tremor, sleepiness, severe difficulty breathing, and difficulty feeding. Reports of extrapyramidal symptoms, jaundice, hyperreflexia in infants whose mothers took a conventional antipsychotic during pregnancy. Psychotic symptoms may worsen during pregnancy and some form of treatment may be necessary. Atypical antipsychotics may be preferable to conventional antipsychotics or anticonvulsant mood stabilizers if treatment is required during pregnancy. For breastfeeding, some drug is found in mother's milk, breast milk, so recommended either to discontinue drug or bottle feed. Art of psychopharmacology. The potential disadvantages, potential advantages is that Flupenthixol that can be used in non-compliant patients. Disadvantages for children, elderly, and patients with tardive dyskinesia. Primary target symptoms are positive symptoms of psychosis, negative symptoms of psychosis, and aggressive symptoms. Here we have some pills, less sedation and orthostatic hypotension, but more extrapyramidal symptoms than some other conventional antipsychotics. Patients have very similar antipsychotic responses to any conventional antipsychotic, which is different from atypical antipsychotics, where antipsychotic responses of individual patients can occasionally vary greatly from one atypical antipsychotic to another. Okay, this is important. Less sedation, orthostatic hypotension, but more extrapyramidal. This is for Flupenthixol. Let's continue about that. Patients with inadequate responses to atypical antipsychotics may benefit from a trial of augmentation with a conventional antipsychotic such as Flupenthixol, or from switching to a conventional antipsychotic such as Flupenthixol. That's not the right thing to write here, but I don't know. However, long-term polypharmacy with a combination of a conventional antipsychotic such as Flupenthixol with an atypical antipsychotic may combine either side effects without clearly augmenting the efficacy of either. For treatment-resistant patients, especially those with impulsivity, aggression, violence, and self-harm, long-term polypharmacy with two atypical antipsychotics or with one atypical antipsychotic and one conventional antipsychotic may be useful or even necessary while closely monitoring. In such cases, it may be beneficial to combine one depot antipsychotic with one oral antipsychotic. Although a frequent practice by some prescribers adding two conventional antipsychotics together has little rationale and may reduce tolerability without clearly enhancing efficacy. So that's all about Flupenthixol. Okay, here we have some suggested reading. We can do that. So that's it.